Good afternoon, dental internet world. My name is Dr. Vishal Sharma, and I'm sitting here with my friend and colleague, Dr. Mike Parchewsky. Mike, it's March 1st, and I hope you know what that means. It is Dental Hygiene Month, and that is a perfect aspect because our podcast today is going to be on the dental hygiene examination. Good to see you, Mike.
Good to see you. How are things been going for you?
Yeah, it's obviously here in Alberta, some of the restrictions are starting to lift. COVID numbers are significantly down, and the mask mandate within the province was lifted today. Obviously, within our healthcare facility, we are still following it. But things have been good. I'm excited to hopefully come out of this phase of the pandemic. What about yourself?
Similar. We've been finding that we still have that weird, as the restrictions come off, I think in healthcare, we sort of have to toe the line a little bit longer. So at our office, our plan is to stay consistent with the PPE protocols, at least for a few months. Just make sure things are coming down. Patients get comfortable. It's interesting. We're starting to see a lot of the patients coming back into the office, and there's still that, that leeriness about being around others. And I think COVID has really created that, do you shake hands? Do you not shake hands? Do you get close to somebody? Do you not get close to us? It's created that sort of everybody's sort of infectious feeling. And I think at the dental office, there's still some uncomfortable people coming in. And so I think it's up to us to just, make them comfortable, make sure that they're aware of what we're doing for their safety. And people, and as things settle down and as people are coming back to work and feeling more comfortable being around other people, I think a lot of this in the next 6 months will settle out.
Yeah, I know. I would agree with you. I think the barometer for a healthcare facility, even a dental office, is different in that oftentimes coming to see us, it's not optional for people. It's part of their health. If you don't want to go to Tony Roma's to get ribs because they're no longer having a mask mandate, it's a little bit more optional. So I think that the approach that you guys are taking is certainly the right one. But lots of ambiguity in the world, lots of different opinions in different directions. One of the topics that we're going to be discussing today is the directions with which to take your hygiene examination. So let's jump into it, Mike. I'll let you start off the topics, and looking forward to the back and forth discussion on this.
Right on. So yeah, we've got a few topics here. I know this has been an increasing discussion about technology and the dental hygiene chair, and the way that the dental hygiene chair is a hub in the practices. And more dentists, I think, are realizing that even though a preponderance of the dollar bills that are coming in is related to what they're doing in their dental chair, a lot of the research has shown that more treatment is accepted from your dental assistant and from your dental hygienist. Mm-hmm. And so if you don't set up your office around your recall and around your hygiene systems, you are really sort of missing treatment opportunities. And, the people that have the most time with your patients are your hygienists. So I think for a lot of dentists, it's for us, I know we've been always on the digital side, very proactive, and our hygienists and our assistants have always been, taking things to the limit of their scopes. But I think, more and more dentists are realizing that, they can't be the only one to scan, the only one to take photos, the only one to talk to patients. You need that team approach. And more and more people I run into when we start talking about this are very shocked that how much autonomy we give to our team. And whereas you and I would take that as that's the way to do things, for some people it's a push out of the comfort zone. And again, that brings us to our first topic, which is the importance of that hygiene chair for building a restorative practice. And so I've touched on a few of them. What are your thoughts on this ever-changing model that we're seeing in the more modern technology practices?
Well, I echo your sentiments in that, we are working in a facility where there's oral healthcare providers. There's the dentist, obviously hygienist assistants. Each of them have their individual role, but that has to work in sort of concert with the other practitioners as well. So, a dentist coming in for a recall examination, it's no longer them just discussing the teeth, and the hygienists are concentrating on the gum tissue. We understand, of course, that there's a very strong relationship with that overall system, and that's going to contribute to overall health outcomes as well beyond the mouth and the head and neck. So I think having practitioners that understand everyone's role, supports everyone's role, and takes a more holistic or overall viewpoint when evaluating a patient's dental health is the important aspect. Strong communication, strong continued ongoing education is important from that perspective. If we're looking at it from a numbers aspect, yeah, you're absolutely correct. All the studies are indicating, or the research indicating, that I think it's 70% is the number that's thrown out there, that they're going to look for validation. 70% of patients will make their decisions based on what the assistant or hygienist is saying, as opposed to the dentist. Makes sense, because your hygienist spends a lot more time with patients. But from our perspective, we want the hygienist to be discussing not only gingival health, but decay, restorative health, parafunction, all of the things that are going to contribute to gingival and overall health. So, technology is great from that perspective, but I think just paying attention to it and communicating it is important. And then, of course, part of that is ensuring that you have the appropriate team. So, Mike, you have a well-developed team. They're very knowledgeable. You have some very tenured team members here. Talk a little bit about picking, the right people for that team.
Well, I think it starts off, it starts off realistically with people that are people. People. Can I say that?
Yeah.
So I won't say it 5 times fast, though. Picking the people, purple people, peoples. But really, when we're looking at it, it's got to be the person that is not just a scaling machine, is not just head down, wanting to scale. They have to be somebody that is looking at the holistic side, somebody that is willing to look at the teeth, look at the patient's health, take a blood pressure. I know in schools, 80% of dental hygienists report having done blood pressure on patients routinely while in school. That number drops to 15% when they're in practice.
Interesting.
So, if you're interviewing a hygienist and you ask things, if you saw a big broken filling or a cracked tooth on a patient, would you talk to them about that prior to the dentist coming in, or would you wait for the dentist? Do you take blood pressure? Do you think it's important to take blood pressure? When you start asking those questions, and if your response is, I would never take blood pressure, I don't have time, I've got to get the scaling done, I would never, that's the dentist's job, I would never, I'm not supposed to diagnose, I'm not supposed to look at that. Then I think, that's starting to put you into the category, is this the right person? So you want somebody that wants some autonomy, wants to be involved, wants to be heard, wants their concepts and ideas to be understood. They want to learn new things. They want to do other things besides scaling. Some of the best hygienists that I've run into are hygienists that say, hey, if I've got an opening and somebody needs whitening, I'm all over that. Or if you need somebody that needs a scan or impressions and there's an opening, let me know. So it's really the self-starters, the go-getters, and I think that's the kind of people you want to look for. The people that will look outside the box, look at their patients in a whole view, and are real good chatters. And because I don't know about you, but I sometimes walk by the hygiene room and it seems they're chatting more than scaling. So it's kind of like when you go to your to get your hair done, and basically you find out they find out about your entire life and you find out about their entire life. I feel like that happens in the hygiene department.
Yeah, it's obviously an environment where strong personal relationships can be developed, definitely distinct from a dentist-patient relationship for the most part. You're bang on, obviously, on picking the right person. Any management course is going to tell you hire really slowly and obviously choose attitude over experience. From my perspective, I'll sort of clarify what you said, or if I was to pinpoint it, it's hiring a professional. And, you mentioned the term go-getter, or someone who, is going to think outside the box or put their patient first. For me, a professional is someone who is constantly trying to craft or hone their craft and improve their skill set. Someone who, if they encounter a scenario Though they're willing to do a bit of research after work. I'm not talking 2 or 3 hours, but 15 minutes looking at Perio Protect. Maybe looking at some options on sleep appliances. If they have a patient who's on bisphosphonates, just doing a little bit of research as to the long-term implications of stuff like that. And I think that really for us is the key aspect, is having people who are interested in being a better oral health care provider next year than they are today.
Yep.
And these are conversations that I recently had with 3 of our hygienists. In fact, this week we're back to doing those connects that we discussed a while back on team culture. And it's exactly the conversation that I've had with 3 of my hygienists, Zara, Amrit, and Ashley today, is just about honing their skills, and that I admire the fact that they all are professionals interested in being better. So yeah, I would echo that aspect for sure. Let's pull a bit of a left turn and start discussing not only just the right people, but patients. And if your office is one that's starting with hygiene as an intake exam, how are you converting those patients and getting them back for a full examination? Or are you in your office typically having patients come in for a new patient exam first? Go ahead, Mike. Let us know what you're doing.
So on the conversion side, I think what we're talking about is you've got a patient, in the dental chair. Let's say your office has taken a look at some sleep apnea, integrating sleep apnea, has taken some new courses, new training, and now this patient that's been in your office for 15 recall cycles, been there for 10 years, and all of a sudden you're looking at them in a new lens. You've learned some new things. You've learned about occlusion. You've been to a COIS course. You've taken one of our courses, and your life has now changed. And so now you're looking at your patients with a new lens. And so now, or you've trained your team, and your team's been to these courses, and they're looking at the patients in a new lens. And so it's often, how do you take that patient out of that regular recall regimen and then say, hey, you know what, Jim, we've learned something new, that we have a feeling that you might be a candidate for sleep apnea, and the getting tested should be important, and we want to take a more thorough check of this. We want to do an airway scan. We want to do a sleep study on you. And so we're going to move you over, or rebook you to come in for a consult, or rebook you to come in for a scan. So I think it's really just honest conversation. And I think it's empowering your hygienist to be able to have those conversations with the patients, to be able to recognize those flags and those cues that we provide. And same thing for us. And don't hesitate sometimes just to say, hey, I now have learned or trained, or I'm doing something different. I think we just have to sometimes be a bit humble and be honest with our patients to say, you know what, I'm looking at things in a little bit differently here. You fit that category. Do you mind coming back so that I can do a more thorough exam? And patients appreciate that.
Totally. Everyone wants their healthcare practitioners to be better, to learn new skills, and again, to evolve. So I echo that sentiment. Is just simple wording such as, if you're in the chair, just saying, Mike, as you know, our office is committed to continued excellence, or continued education, or always bettering our craft. We've been taking a lot of courses on dental sleep medicine, and we just, in reviewing your file over the past couple of years and what I'm seeing today, I'm seeing some things that I may not have been able to see before, given all this new information. Can I have, Dr. Parchewsky come in and talk to you about this? And I agree with you with that. It's never really been an issue where people are like, well, this is the first time I'm hearing it.
Yeah. So, yeah, I like that. And, it's find a problem, target the problem, provide a solution, and then, give them the conversation that says, the solution is going to require a bit more in-depth work.
Yeah.
And let's get you back for some more information.
And one quick interjection is, in terms of the solution, one of the things that I ask of the hygienist is actually just for them to identify what they see.
Yeah.
So inflammation, recession around this tooth, wear, attrition, sensitivity here, crowding in this area where there's a lot of buildup. Just identify exactly what they see. They don't necessarily need to say, yeah, you've got crowding here, 15 months for clear aligner therapy. That's the solution. Just identifying that issue. And if the patient is obviously, they have deepened concern, they're asking for solutions, giving them possible solutions, and just saying, but, it's not my area of expertise. Dr. Mike's going to come in and discuss that in detail with you. That's really what we're asking of our team.
So on that note, I'm going to jump ahead to one of the interesting communication skills that I've learned actually from you. So there's a term you use, WARP, WORP, and I think it's anybody that I've talked about it has thought, wow, this is a really nice way to bring this together. So can you go through everybody about what WARP is and how that relates to communication?
Yeah, obviously one of the challenges with implementing anything new in any job, especially in dentistry, is we're just so accustomed to doing things the exact same way. So for myself, I find that checklists, a readily available checklist or prompts, is the best way to break out of the consistent homeostatic mind frame that you might have. So for us, some of the major things that we're looking for in our adult-based clientele is where. So is there signs of parafunction? Is that parafunction progressive? Is it getting worse? Are there clear indications that this person might be clenching, grinding, or has worn down their dentition? So hence the W in the acronym WARP. The second aspect is occlusion, which ties in very closely with that. Do they have a malocclusion? Are they a potential ortho candidate? Are they past ortho with relapse? What's the scenario from that perspective? And so that's the O component. R is restorative. Whether it's signs of decay, cracked, leaky restorations, leaky amalgam fillings, old PFMs, etc. And then the P aspect, of course, is perio, where the hygienist is going to give a definitive diagnosis, not a jargon, generalized advanced periodontal condition. We don't necessarily need their APA classification, but just something that's really simple for them to understand. Mike has good oral hygiene. He's flossing 2 to 3 times per week, so there's some room for improvement there. He has some inflammation that we see is present. It's a bit concerning. I've suggested that he comes on a 4-month interval, and we've classified him as, we use John Coyce's green, yellow, red. We've classified him as a yellow. And so my job then, reiterating that WARP aspect and certainly emphasizing the P at the end, is to say, well, if our hygienist Mike is suggesting that you are in a yellow category, we really want you to be in a green category. So the ultimate goal is, if you're on 4 months, if you can make some minor improvements, we want to get you to that point where at green, there's not a lot of long-term concerns that you're going to have issues as the years and decades go by, blah, blah, blah. So that's what we utilize. And it's just the sequence to allow the hygienist to discuss things sequentially. And we really try to avoid good. Good is not a diagnosis. And obviously we want to reinforce positive behavior. We want to give our patients strokes or create positivity where it's justified. But at the same time, they're paying really good money, not for us to make them feel good, but to give layman's terms English diagnosis that they can have a really good gauge as to where they're at. So yeah, WARP is what we use. It doesn't sound very sexy, but it seems to work. It seems to warp. Yeah.
I don't know. You can say warp speed, Captain.
That's right. And so what are you guys doing in your office, Mike? Because you guys cover obviously a lot of things. You're a technologically advanced office. How do you sort it all out?
Well, it's interesting. We had a sort of a checklist protocol, and when you told me the acronym, we actually adopted that because I was like, okay, well, this makes a lot of sense. And I'm going to tell you what I really like about your acronym is that I really feel that, based on things such as John Coyce and other researchers, that, any wear on the teeth, beyond microns a year is significant, and that we shouldn't be having millimeters of wear. We shouldn't have 3 millimeters of wear in our teeth. 50 microns or 100 microns or, over a long period of time, a fraction of a millimeter, okay. But when we see millimeters of wear, that has impacts on everything. And so I do think that wear is in our mind too one of the key things we're looking at. And then I like the O because wear is talking about the occlusion and overall health. So it's really it really takes you into the muscles, TMJ, and overall health. So I think that's the most outlined thing. And of course, a medical history update as well, totally, I would argue. And then the O, when we talk about the occlusion, is then we're talking about how are the teeth aligned to each other, and is there crowding? So I think that's the next important thing. And then restorative, obviously that's important. That's what we do a lot of. But if we start with restorative, we forget about the wear because we say, well, there's a filling. Okay, yeah, 2.5 DO. I got to go to the next room. I'm supposed to do another CIRAC. And I think, but they are thinking perio.
Yeah.
So if we let them start with perio, then we never get to the WOR. So it's actually been a big game changer, because previously we had the perio check part first and then restorative, and then we went into sort of the other, which was the occlusion and wear. And by flipping it around, so I'd say this is a massive pearl out there for people, is that start with the wear, move into the occlusion, talk about the restorative, and then the perio. And if you get your hygienist on that, it is making them really assess the patient as a whole person. And so that, to be honest, that has been a real big game changer for our hygiene team. And that's, within, realistically, since you were telling me about that, maybe 6 months that we've been doing that.
Yeah.
And we've been finding it super helpful.
It's nice to have a roadmap. It's easy to follow that. And I think the hygienists also appreciate being oral health practitioners, where it's a more holistic overall viewpoint from that perspective. So one thing that we have not been very effective at in our office is incorporating scanning with the hygienist. We've tried over the years, just have struggled with making it effective, or even in my mind necessary, with the busyness of the hygiene schedule. And we do a 70-minute hygiene appointments, as you know. But you guys are starting to do that. Talk me through that process and what the justification on it is.
So the thought of using your hygienist as a scanning hygienist, as it were, kind of comes from two thought processes. One, we'll talk about this in a minute, about the way we do our new patient exams. But if we talk about the scanning hygienist in the recall realm, what we're saying is, as we're using basically our scanner as a twofold item. We're using it as a model, being able to take models of your patient. And two, we're looking at it to establish digital photos, right? So it's kind of like an intraoral camera and a T-scan, let's say. Mm-hmm. And then we have records. And the neat thing is that oftentimes parafunction or occlusion issues, lead to abfractions or lead to issues of the recession and gum issues. So it often helps in that workflow when the hygienist is able to scan the patient and say, and we're trying to implement it on an annual basis. Yeah. So that they would scan the patient, and then they're able to say, look at their bite. They're able to make note of where we're able to analyze, is there differences between the last set of models and this set of models? Is there more wear? Is there more recession? And so we're seeing sort of real-time data in that manner, and we're still being able to use it to get photos, right? And you can render out the pictures. So it's something that we've been working on through COVID, is trying to implement, and it basically what we're doing is adding that extra 10 minutes. So we're doing an annual visit where we're ensuring blood pressure is being done, we're ensuring we're updating medical history, we're ensuring that we're doing a scan, and so we've had to actually schedule it that way.
Okay.
Right?
Yeah.
And then, I think that takes us into the next conversation is there's two ways really to do exams. We can either have the exam that starts and occurs in the dental chair, or we can have the exam that goes through the hygiene chair. And we're not talking about the traditional, the patient comes in and the dentist does a 5-minute exam in their hygiene chair. We're talking about an actual new patient that's being taken care of in a thorough manner in the hygiene chair. Now, what do you do currently? Do you do either of those? Do you do one or the other, or do you prefer one or the other? What's your thoughts?
So my strong preference is the intake evaluation for a patient is a new patient consultation with myself and my dental assistant, where we are doing still intraoral photos, SLR or iPhone, fully retracted views, occlusal, buccal, maximum intracuspation. We're doing a full prime scan, top and bottom. So we're using that occlusogram that you were talking about, tracking where the recession is. This upcoming Friday, Dentsply Sirona has a big announcement that they're keeping under wraps. I think it's no secret that it's going to be prime print, the printer. And there's some intimations on Google Cloud. So I'm guessing that the scans that we now take in our new patient exams will be able to be saved to a cloud version, which is much better than the intra-office network that we're currently saving those STLs to. So now you have the ability for hygienists to pop up those scans moving forward in the future, or you've got that reference a year later where you can take a scan. So we do our intake evaluation that way. It's an impressive evaluation. We are discussing short and specifically long-term concerns. We're doing a generic perio assessment with some spot probing. And then after that, they're going in to see the hygienist, typically at a different visit or a different day. On occasion, we'll have someone who, based on scheduling, will see the hygienist first. Typically, we'll go in and introduce ourselves. But I'll tell you, the conversion rate from our new patient evaluation to first treatment is exceptionally high. If they're coming in for a new patient exam and then they have some simple restorative and the hygiene visit, exceptionally high, it's dropped off precipitously the opposite way. And I'm not sure why that is, where if they come in for a hygiene visit and then they book for a new patient exam, the cancellation rate on that is quite a bit higher. So I like having them come in first because we're establishing all the records. It's an impressive evaluation. We're differentiating ourselves from their other potentially non-digital office. So obviously if they're seeing you before, it's not much of a difference in any capacity at all. And so that's the approach that we're taking with it. And that's what I really like. To further add to that, as you know, every 4 to 7 years, depending on the person's restorative status, how much dentistry they've had done, what their preconditions and predispositions are, we're booking them back for a full diagnostic reeval, where we're re-updating those records and then comparing to the previous version.
And sorry, what was the time frame you're using there?
So it varies. It's typically between 4 to 7 years that we're doing.
Okay.
Like if it's a really low dental need patient who's had ortho, they're in some sort of parafunctional appliance, we don't need to see them at 5 years. It's typically 7.
Yeah.
If it's someone who has a lot of other issues, we're worried about deterioration, progressive recession, et cetera, we shorten that time frame.
Yeah, I like and I'll be honest, we haven't been the greatest on that philosophy, but in the thinking about it, I do think that we can tie that 5 year as a nice number. I think for people listening, if you want something as a strategy, I think about it as a 5 year plan, because when you think about it, you have a new patient comes in as a baby. At 5 or 6 years old, you want to get that pan. Then at 12, you're trying to figure out the mixed dentition. Then you're getting into wisdom teeth. And so if you look at the phases in life, the 5 year reeval seems to fit.
Yeah.
And not to say that we were timing it on when we're doing our new CBCT or pan, but if you think about that and you were to tie that together and say, that's when you're taking your CBCT, if warranted, low dose if needed, or standard dose. But you're using your algorithms that you learn on CBCT. But if you take that into account, that say, this is where we're going to just stop for a moment and break everything down and get back to it and reevaluate, I think patients respect that. And a lot of patients might look at you and go, wow, it's been 5 years.
Yeah.
And so I think I really like that idea. And I think that's something... look at all these things I'm learning here. I think that's something we have to go back. There's a bit of a time warp that's occurred through COVID, I think. And I also think there's a lot of our patients that are coming back in after 2 or 3 years now, where I think that might be warranted to go back to that. And my question for you is, I'm going to talk a bit about the hygiene exam, but my question for you before we go on to that is how do you convert those patients that just have been missing through COVID and say, hey, you know what? We need to get you in for a full reeval. What's your thought on that?
So oftentimes it's going to come out of hygiene. If they have been a patient of record and they're coming back for a hygiene evaluation, they're no longer as COVID concerned because numbers are down and they've got their booster shot. The hygienist is essentially saying, we can have Dr. Mike in for a really quick evaluation, but it's been a number of years since we've updated records. We notice there's been some changes with gum health, et cetera. It's going to be worthwhile to come in for that full evaluation. You're going to find it extremely informative, and we're just able to update the baseline data that we had taken X number of years ago. The other aspect with the 4, 5, 6, 7 years, whatever it might be, is typically there's a technological jump as well. So now we're doing the prime scan.
Right.
Before it was a T-scan. Before it was just SLR photography. So there's some credence to that as well. I will tell you, you know, the Pearl for Warp was great that you chimed in on. This has been a really great addition to all of our practices. The one that we have that I don't ever practice at, the dentists there have recently incorporated it, and you know, just they're talking about how fantastic it is. Obviously, we're aware of that. So, yeah, that's how we re-engage a patient from that perspective, and that 60 minutes on the reevaluation with the dentist going through new technology, I think people really appreciate that.
Yeah.
Yeah, and go ahead now, Mike. You were going to discuss the hygiene evaluation.
So what this was is we talked about the two ways to do the new patient exam. One is they come through the dentist side, and one they come through the hygiene side. And I'll play devil's advocate here, and I'll say that historically we have found that our patients tend to be in a bit of a rush. We're in the downtown core, meetings, this, that. Their time is tight. We can get them in for multiple 1-hour visits. It's harder to get them in for longer visits. And we do find that with that new patient exam, because a lot of patients just call and say, I'm moved here, just had a cleaning a year ago, I just need a new checkup, and I need my teeth cleaned. And so we end up with a lot of people coming through the hygiene side, and so in the past, the problem we had is as they come to the hygiene side, they also wanted an exam. And then I'm limited in time. And now I'm banging my head against the wall because I don't have enough time. And now we're trying to convert them that, hey, you have to go now, you have to come back. And so there's a struggle there in changing expectations. And so part of it is getting your front end to know better about qualitating what you're doing, how you're different, how you're going to be, bridging that into the new patient exam, why it should be done in the dental chair first, what your practice goals in. And so whatever you guys figure out and decide, I think you have to make sure that everybody's on board with the scripting. Now, but on the flip side of it, there's been this talk and there's been a lot of this coming out right now about the movement of the exam going through the hygiene chair first. And the reason for it is, one, is that if we look at the numbers and we look at where patients accept treatment from, it tends to be from the hygiene. And if the hygienist is going to be the person that's talking to these patients every time in the future, they're developing that relationship with them from the get-go. So if you do that new patient exam and you've put it all together and you've done this massive treatment plan, and then they come in for the hygiene and the hygienist does not tie into or is not involved in what their treatment is or treatment expectations or treatment plan, she might say, hey, the gums look pretty good, whatever, hey, good, we'll see you in 6 months. And there was missed the treatment, there was a plan and there was action and things that were needed. But if that hygienist is part of that initial intake and is with that patient from the get-go, then when they see them again, they're like, so did you get those crowns done? Well, that's great. That's going to reduce your risk. And great, that's going to help your health. And hey, what was happening next? What did you ever do about the crowding? Did you go with the Sure Smile? What did you do? And so I think if they're going to be that quarterback and they're going to be the one that sees that patient, and I'll throw another stat out there. Some say that you have to hear something 7 times before you do it or accept it.
Interesting.
And so if you think about it, if that hygienist is going to be the one that talks to them about the Sure Smile or the veneer case or any cosmetic type whitening or Botox, she, the more times that she sees that patient, the better.
Interesting.
And so I think when we're kind of looking at it from, a different angle and trying to get the patient through the hygiene chair, but now what's the issue there? Well, you're taking a person that normally was sort of scaling machine and you're saying, whoa, hang on now we're going to give you much more time. And what we want you to do is we want you to do scanning. We want you to do, so now you're training, you have to train them, you have to get them up to speed. But I tell you, it's been really successful. And the reason we made this move is we had lots of cancellations with the different variants coming through. So all of a sudden in our hygiene chair, we had more time. I was still fairly busy because we're still getting emergencies. We're still getting different things that are coming in, referrals, sleep patients, or a wisdom tooth case or something. But the hygiene chair is where we had the gap. So we started to do is converting them. Well, we've got a prime scan and we've got all this stuff. Let's get you guys using this stuff. And so we found that was a nice way to make up for openings where they could take more time with the patient. And I tell you, the patients have really enjoyed it because I guess they feel like they're in a comfortable environment. They don't feel, again, dentists don't let it, crush your ego here, but a lot of times patients feel more comfortable when they're with that hygienist, as opposed to worrying that as soon as the dentist comes in, it's going to be expensive.
Yeah.
So it's just a little bit of a change of paradigm. And I when we talked about it, I really wanted to bring this out today in our conversation. But it is something to think about and to talk with your team and to build on. What's your thought on that?
Well, I like the approach because obviously, even though we're not following it, some of our strongest communicators, if not our strongest communicators, are hygienists. So you want to utilize those assets to obviously best represent the business. And the ultimate goal of the business, of course, is great patient outcomes. That leads to a percolation in every other aspect. Staff satisfaction, patient satisfaction, your bottom line gets better as well. So even as you were talking, I'm trying to conceptualize using some of these exceptionally strong communicators and how to shift it. And it is a paradigm shift. It's a scheduling shift, etc. When you're busy, it's more challenging to implement that change, but we're always trying to be better. So, that's going to be a pearl that I'm going to look to do and see how we can incorporate it. So you'll probably be getting some text messages from me asking lots of questions.
I'll just answer back, warp speed, Captain.
That's right. Well, and on that note, time to beam me up, Scotty. Mike, it was a fun podcast. We've got some upcoming presentations at the Academy. I've got some ortho presentations. And speaking of those CBCT algorithms, you'll be teaching some courses as well. Unfortunately, Pacific Dental Conference next week is going to be postponed. The live event will be in 2023, where you and I will be presenting our lecture from this year. But don't worry, we'll be back well before 1 year's time. We'll be doing a podcast within a couple weeks. So thanks for tuning in, everyone. Mike?
Yeah, thanks, everybody. And for all of you who are new to the podcast, check out some of our previous ones. We do post on our YouTube channel, The Digital Dentist. We do post a lot of information and how-tos, and we will continue to build that out. Instagram at Digital Workflow Dentistry, digitalworkflowdentist.com for the website. Tune in and follow anything you need to know. Send us messages, direct message us through the Instagram. Everybody take care, and thanks a lot, and make sure you subscribe.